It's a two-way, right? You can't just go one way.
Alrighty. Good whenever you're ready to go.
Okay. Okay. We'll give people a couple more minutes to get settled. Brandon, can I ask you to pull the doors too, just so that the recording's better for people on the phone and the sound's better? Thank you.
No, I know, right?
Thank you. Okay, can people in the back hear me? Okay, the mic is on. Perfect. Okay, we're going to get started today. For those of you who don't know me, I think I know most of the people in the room, but I'm Lindsay Harris. I'm the Chief Client Officer here at HMA. I lead our sales, marketing, product, and account management teams. Welcome. I'm super impressed to have so many people here deep into fourth quarter, so thank you for making the time. Hopefully you'll learn something. We're going to talk today about a topic that's dear to my heart. So I moved to Washington in 2005, and my first job was working on pay-for-performance programs for Primera. And value-based care and pay-for-performance are highly related. They do a lot of the same things, and so this is kind of back to the future for me. So it's really exciting to get to talk about it with you today. We are going to go through this in hopefully about 45 minutes, so we get you out of here in under an hour. But please stop me and ask questions throughout if you have questions on topics or any of the specifics. Some of this gets into some regulations, so I will call mercy if I get to the point I can't answer the question, but I'll do my best. All right. So today we are going to talk about, first of all, we're going to talk about how most care is paid for in the United States and kind of what the status quo is with regard to payment for healthcare. I've got some things coming up. Not sure where that is. Okay, hold on. Okay. We'll talk about what value-based care is, how that shows up in the US. Value-based care is something that happens in many places throughout the world. Today we're going to focus specifically on our healthcare system and value-based care models that exist in our care system today and that have been evolving over the last few years and will continue to evolve into the future. We'll talk a little bit about laws and regulation that support value-based care and what the future holds as we evolve forward and we think about where it might go. Okay, so let's start with just some groundwork here, knowing that lots of people in this room come from different places with respect to their understanding of healthcare and their background in it. So I'm going to start just with the kind of the basics. So today, most care that we have is paid for in what's called a fee-for-service model. Essentially, a provider renders a service. I go to a provider's office and have an office visit. The provider then submits a bill to my plan on my behalf with a specific procedure code that says that they saw me for this and provided the specific service and that they need to be paid for it. And then from there, the plan pays for that care, right? And so that's called fee for service. Provider performed a service, a specific procedure. There's some rubric that says how we pay for that. In general, we use the contracted rate. And you can see in my example, we're saying a contracted rate. That makes an assumption that there's a PPO network in place and that there is a contract with that provider that dictates what they will be paid for that specific service. In some cases, we have out-of-network care where we don't have a contract that says what they should be paid for that. And in those cases, we generally use another fee schedule. There's a couple of fee schedules that come into play. One's called usual and customary. There's a kind of fee schedule of what's common in the industry in a particular region for a service. Or we might use a fee schedule such as Medicare as a rubric that tells us how much we pay for it. But regardless of which schedule we're using, we're saying you did X and we will pay you Y. Does that make sense to everybody? Okay. And I do want to note, there are, in hospital settings, you may hear of something called a DRG, a diagnostic related group. And essentially what that is a case rate that's provided for hospital stays. That's a little bit different. It's more of a case rate methodology as opposed to a fee for service. But this is, fairly ubiquitous across all outpatient care, any physician office visits, those types of things. It's the predominant way in which we pay for care today. Okay, so I guess if we think about that, there's lots of things that are not considered when we have a fee for service system. We do not consider, generally, could the care have been avoided in the first place? Did I need that office visit? The fact that the provider saw me means they get paid for it, whether or not I needed to be there or not. Was the service appropriate? Was it redundant? Was it coordinated with other providers that I may be seeing? Did the service generate any sort of intended outcome for me? Was it valuable? And did my plan generate some outcome in terms of cost savings by me having it? So I may go to the doctor a lot and just really enjoy sitting in the waiting room and going and talking to my doctor for the 7-minute visit that I get. And so I may just go a lot. And there's really no method in the system to say, is that appropriate or not? Now, we here at HMA have our medical management team, and they perform pre-authorization, and they do some utilization review to say what's appropriate and is it in the right setting under certain circumstances for some of the high-cost care. But for the most part, if you think about a large number of services, nobody's watching that to say, was that right? Was that the best thing? Was that necessary? And when we think about it, there's some really potential negative incentives that go along with that. I'm going to caveat this by saying, I don't believe that any provider out there, or the vast majority of providers out there, went into medicine saying, this is the best way I can think of to make money. It takes too long, there's too much schooling, and really it's a calling for a lot of people as they think about why they go into medicine. So I'm not in any way suggesting that doctors are not good or that they're not looking to do the right thing by their patients. I think on an individual level, they definitely are. But if you think about it from a systematic perspective and what a system is incentivized to do, then I think the picture is a little bit different. So first, providers earn more when they render more care. So then the corollary to that is it's beneficial to do more. So if you go see a back surgeon, as an example, and they tell you, you should really go home and go for a walk as a way to deal with your low back pain, as opposed to, I'm going to give you this back surgery with an implantable device that I'm going to get paid $100,000 for. The incentive is to do the surgery versus to tell you to take a more conservative measure. Again, not calling out any specific providers, but the systematic incentives are there. So first, we know that. It encourages overuse, and it also encourages use of procedures that get paid at a higher rate. So if we think back to my office visit, if I just go in and I have an office visit, my provider gets paid one thing. If they do a bunch of things to me through the course of that visit, then they get paid more. Let me tell you my personal example, the one that just irks me. So my daughter, when she was 2, went to a pediatric office, and she might have had an ear infection, right? And so the doctor examined her, and they decided that perhaps they couldn't look into her ear carefully enough. So they performed a procedure. You know what the procedure was? They used a Q-tip, right? No joke. They used a Q-tip, and I got charged $125 for it, right? Because it's a procedure. They stuck something in her ear. It was a procedure as opposed to just a consult. And if you think about that, for the more aggressive procedures that people may have, the more that they do, the more that they get paid. There's also a disincentive to wellness. So again, not at the individual level, but if you think about this from a systematic perspective, not only do you have the incentive where the more things the provider delivers to you in a fee-for-service environment, the more that they get paid. There's also systematic incentives when you think about the health system. So if you're the University of Washington and you have a choice between investing in diabetic educators and a program to help people with diabetes to prevent them from being more expensive and to prevent them from having worse health outcomes, or you can build a bariatric surgery center, which is a surgery center where they do surgery for obesity treatment. What do you think you make more money doing, right? right? How much return do you have to generate from that diabetic outcomes program? And how many services do you have to render to catch up to one surgery, right? So it creates incentives for our system to create more of that acute care and more of those high-cost service treatment centers, as opposed to doing things on the wellness side. So let's talk about what is value-based care. There's a number of different definitions. I'm going to use this one. You can read what it says here. But essentially, we think about it as a methodology for paying for care that really promotes quality, efficiency, and outcomes. It's focused on delivering value as opposed to volume, right? So it's focused on, did the service that we provide have value, whether that's a quality outcome, whether that's patient satisfaction, whether it's a reduction in cost for the payer, as opposed to just saying, you did something and so you get paid. Does that make sense to everybody? Okay, so let's talk about this a little bit deeper way. So first of all, as I said, when we think about value-based care, we're talking about paying for value. What that means is that in general, providers are paid for generating a positive outcome, not just based on the services rendered. The outcome is typically a combination of quality. And when I talk about quality, what does that mean? There's a variety of measures out there that we talk about healthcare quality. Some are process measures, like if you go to your doctor for your wellness visit, if you're diabetic, did they check your blood glucose? Did they check your cholesterol? Did they check your kidney function? Did they check your feet? These are all important things to do. Those are quality measures we think about. Did you get all those things done? Are you compliant with all the things that are appropriate for your age, your gender, and any medical conditions that you have? Next, there's cost. So overall, are we reducing the cost for the payers, which are both carriers and insurance carriers, as well as for us, the employers that we serve? And then also patient satisfaction. So through all of this, did you actually satisfy your patients? Now that's a difficult one. As patients, how happy are we when the doctor says, go home and just wait, right? Okay. Does anyone know what the number one driver of patient satisfaction is in the office visit? Prescriptions, good guess. Waiting time, good guess. Okay, number two things. Was there free parking? Was the receptionist nice to you? Okay, so as we think about healthcare and we think about quality and the things that drive value for the system, as buyers, we don't necessarily buy that way. And so it's something for us to consider as we think about what's really value. In general, when we think about value-based care, it's a population approach. So it's not just about what does my doctor do for me. If we all see the same doctor, it would be about how does that doctor serve us as an entire population? Because I could be a really terrible patient. That's probably true. I may not do all the things I'm supposed to do for my health. I may not follow up when they tell me to. They may call me 10 times and say, Lindsay, go and get that doctor's office visit. And I might say, oops, sorry, I've got this client visit I got to go to, and I might reschedule 3 times. So on an individual level, it's difficult. So generally, you're talking about a population. And then typically, we're talking about focusing on primary care as a setting. So where you get the majority of your healthcare, we hope, is in your primary care setting, and really thinking about what do you do in a primary care setting that hopefully helps you avoid getting into more high-cost settings. Okay, there are 2 common value-based care models in this country. And we're going to get into alphabet soup, so let's go. All right, first of all, ACOs, accountable care organizations, are one type, and then the other are primary care medical homes, or PCMHs. Okay, so I'm going to talk about ACOs first. In general, an ACO is a healthcare organization that bears risk. Generally, it's a system or a network of providers that come together that decide to take on a population of people. Generally, it's primary care and beyond. They cover not just the primary care things, but all the specialists and facility types of care that you might need. And they generally own the majority of the members' care. Okay. A primary care medical home generally focuses on just primary care. And the idea is that they're going to use a team approach in a patient-centered focus of kind of putting the patient in the center and saying we're going to wrap around the patient to provide them with all of their care needs, hopefully to keep them in primary care and to really do a great job there. It's focused on coordinating their care so that if they do need specialist care outside, that they're coordinating that, kind of bringing it back to the medical home. It's focused on health coaching. You might have a diabetes educator, you might have a health coach, you might have a nurse that are all helping that doctor to work with that patient proactively to really help them address the things that they need to do for wellness and for taking care of themselves over time, hopefully so they don't need to exit the primary care medical home to go to specialists and other services for more. Does that make sense? Okay. In general, primary care medical home is going to have some extra things that you don't get in your typical 7-minute office visit with your doctor. So one, if they're not billing through a fee-for-service structure, some of them don't, then they can see you for longer. So you might get to see a doctor for a lot more time. They might have email communication with you. They might have a 24/7 nurse hotline and or telehealth options and or even some home visits in some cases. So they're unencumbered by some of the structures that allow them to get paid in a traditional fee-for-service model. And so they often can expand their scope of services to meet the patient's needs more holistically. A perverse thing in our system, in primary care today, in a fee-for-service model, you can't get paid for smoking cessation counseling. There's no separate code for that allows you to get paid more for it. Seems like a pretty important thing in primary care if you think about it. There's no way to get paid for it. So it falls off the list in terms of priorities for systems to make sure that those things are done because there's no way to bill for it. Primary care medical homes don't necessarily have those same structures because they're taking care of the patient more holistically. Does anyone have questions about that before I move on to the differences? Okay. So we're going to go a layer deeper. The next question is, regardless of whether we're talking about an ACO or a primary medical home, there's really two models in which patients could be put into one of these things. One is active and one is passive. The active one, where there's patient choice, is one way. And typically what that looks like is the patient would be offered choice at open enrollment to decide to enroll with the ACO typically. They choose a plan with the ACO, and in doing so, they have some incentives to stay there. So they may have a favorable premium to be in that plan to start with, and then they may have lower cost sharing if they stay within that model. Often it's not the case that you only can get care there, but it's highly advantageous from a cost perspective to stay within that system to get your health care. You're also agreeing upfront to the idea that you're going to select a medical home within that system, and that medical home is going to do some care coordination on your behalf. And so you're agreeing to that up front for that discount and premium and some of the lower cost sharing. An example of this would be with University of Washington employees have an option like this. So the UW system has an ACO that they offer, and they offer it to their own employees as a choice point at open enrollment. In that model, they get a much lower premium, they get lower cost sharing. They have to accept the UW services for care coordination. So if you want a mammogram in that system, you have to call the care coordination line and they tell you where you can go, right? So you're essentially accepting some reduction in choice for a more favorable premium. It should sound reminiscent of an HMO model, and you think about like kind of what Kaiser or Group Health does. It's a little bit similar to that. It's not as tightly controlled. There's not as much of a gatekeeper model that says you cannot get specialist care without your provider say so. You have to stay in the system, right? Because they want to know what's going on with you in the system. The other option, which is actually much more common, is the passive model. In this model, the patient seeks care as usual. You play no role in the decision with regard to whether you're in the primary care medical home or the ACO at all. And you're assigned as a patient based on some sort of attribution methodology. Typically, the way that looks is who saw the patient most frequently in the course of the last year for certain types of services. That's a common way that attribution is done. So you may not know that you've been attributed to a particular provider. You may not agree that that person is your provider anymore. You may have decided that you don't like what that person's doing for you and you would prefer to move on. It's entirely passive and it's data-driven. The provider then is responsible for you, even though you didn't know that and you didn't sign up for it. Okay. And I say that to say this is a tough path for providers, right? Because you're trying to take care of a patient population that isn't bought into the idea that you're taking care of them. And so, the patient still has flexibility to choose to get up and walk out when you say go for a walk, as opposed to let me do that surgery for you and go see somebody else, right? And so it's a much more difficult path to make this whole thing fly. Some things that you have to know about attribution. So I started this by saying I started my career in Washington working on pay-for-performance programs. And it's really interesting when you start looking at data around how these programs perform when you start looking at demographic profiles of patients. So first of all, when you have certain safety net providers who provide a lot of care to people who have more significant needs, you have a really large homeless population, for example. You have a really large population of non-native English speakers that you're trying to work with. You have a really large population of people with socioeconomic challenges. It's a lot harder to get things done than it is if you deal with a population that doesn't have those challenges and are more likely to be compliant with the things that you tell them to do. Likewise, if you're dealing with a population that has really rich benefits, it's a whole lot easier to say, go get these 10 things done, if that's all going to be covered, than it is if you're dealing with a population with really poor benefits where they're going to pay out of pocket for all of that. Does that make sense? In addition, you got to think about some of the challenge with this. In many cases, the providers are dealing with multiple competing priorities between the different payers and the different systems they've set. So Regents, for example, might say, you're responsible for the patients that you saw most frequently, and we want you to hit these 5 quality measures over here. And Premera might say to the same provider, you're responsible for these other patients that are our patients, that we've come up with some methodology that decided that they're yours. And we want you to hit these 5 other metrics. And they could be like this close, but not quite the same. And so then you've got this whole mess of things that the providers are trying to deal with in terms of trying to figure out, like, how do you actually care for that population and hit all the metrics you need in order to get paid? Make sense? Okay. All right. So let's talk about how the money works. When we think about value-based care, the concept is if you achieve results, you get paid more. And if you don't, you get paid less. So there's not really a model. It's not a true kind of capitated pay more. It's kind of an all or nothing sort of thing. Essentially, we're saying there's some basis for payment. You provided care to people, so you get paid something. But then it's around the edges either way to say how much, positively or negatively. Over time, the intent is that increasingly the fees are based more on the outcomes that are delivered through the care that is provided, as opposed to what services were rendered. And over time, it's meant, we focus on quality, cost, and satisfaction. So kind of all 3 of those things, not just one lever. If you just focus on cost, then the incentive would be just don't do anything, right? If you focus on quality, the answer would be do everything. And if you focus on patient satisfaction, like, who knows? Offer validation of your parking, right? So the idea is you got to triangulate between those and figure out what's the right mix of services to deliver to your patient base to achieve all 3 outcomes. So let me talk about an example. So in a standard fee-for-service environment, services are rendered to a population. Their care is paid for those procedures, and that's it, right? So if we imagine that there were fee-for-service payments totaling $100,000 in an example for a group of people, say all of our care with the particular provider. In value-based care, generally, there is an adjustment to the network contract that might be provided. So in general, the initial payment for the procedures is lower. So you're actually accepting a slightly lower rate upfront for the same care. But that comes with the caveat of 1, you're going to get paid for care coordination, which is otherwise not billable under any standard billing set of rules. And 2, there's a bonus payment if you achieve good outcomes through cost, quality, and satisfaction that actually has a net positive result for the provider. That means they get paid more overall. So in this example, $80,000 for the fee-for-service, so it's less than before. They get an additional $10,000 for care coordination, so they're below where they would have been had they not done this, unless they achieve outcomes which will then push them above the line to say they get paid more. Does that make sense? Okay. Most models today look like this. Very few models that are in place today have any downside risk for the provider. So there's been a lot more acceptance of kind of profit sharing, if you will, of you achieve outcome, you get more. There's not been a lot of traction yet with providers accepting downside risk, saying if we don't achieve outcomes for the provider or for the patients, that we're going to actually pay that money back or have a reduction. The real downside is if they don't get the bonus payment, they would be net worse off than they are in the fee-for-service structure. All right, so what does it take to succeed with value-based care on the provider side? So first of all, they have to have an electronic health record. It's almost impossible to do this without it. So if you think about a doctor's office and the way medical people think about healthcare, it's a chart, right? You're thinking one person at a time. And so you're looking at the chart and you're looking at that person's history and what's going on with that person. In order to do value-based care, the provider has to think about a population and think about what are the things that I need to do with this population, with specific people in the population, in order to drive to an outcome for the whole group. And so you have to go kind of across people. That's really difficult to do with paper. And so an electronic medical record is almost a necessity to make this possible. Second, you have to recognize, as I said, that most of the providers that are participating, they generally are the larger systems because they have the infrastructure to support this, which means they're generally participating with multiple providers. So I'm going to take UW as an example. UW is participating as an ACO. They participate with Premera. They participate with Regents. They participate with Medicare. They participate with Regents' Medicare program. They participate with Premera's Medicare program, right? Then there's the Medicaid components that they have, and then there's all the other carriers that they're doing it with, right? So you're probably looking at 12 different sets of rules that any one provider is trying to hit against. And so they have a pretty complicated set of things that they're trying to achieve targets on. So what that means then for the providers, they have to step back and say, what are the common things that we have to do, and be successful in evaluating their data and really thinking through what their workflows for care are to make sure that they can hit all of them by the path that they deliver for everybody. This also means, as I said before, that providers have to have different members of their care team. So historically, when you think about primary care, you had your doctor, and they might have a nurse or an MA that kind of preps the room and does some of the support for them. But mostly, what is done in the course of your doctor's office visit, and that's about it. Now you need people to outreach people. You need your staff to outreach members to say you need to come back in for something that's missing. You need to make sure your patients follow up on their prescriptions. You may need to educate them in a new and different way than medical people are generally taught to coach them to behavior change. So that means you got to augment your team with a bunch of different staff and resources and skill sets to be successful in achieving a goal. And then I think the other thing that provider organizations have to deal with to get into this is they have to recognize that they have to get alignment around the larger organization level around what they're trying to achieve. So if we imagine a provider organization is successful, so they go ahead and they set up an ACO and they achieve good results on the primary care front, meaning that they generate higher quality, high satisfaction, and lower cost. The implication automatically then is they just removed their revenue source for all of their high-cost services. So if UW, as an example, is successful with primary care, that means all of those bariatric treatment centers and all of their MRI centers and all of their emergency rooms and all those other things that they've kind of predicated their whole revenue model on are now underutilized. And you think about how many extra care coordination payments does it take to offset some of those services, which are really high from a revenue perspective for them. Like, you have to have organizational alignment. This is a good idea. Otherwise, the incentives are still that you're better off not performing on these models and taking the lower payment to continue to put your revenue flow through to these higher cost services. And again, this is not an indictment of any individual provider, but you just think about the incentives in the model. So for an organization to say, this is the right thing for our population, this is what we believe in as care providers, this is where we're going to put our dollars, you have to have alignment up through the C-suite level to that, because if you're successful, you're going to generate less revenue in your high-cost service areas. Okay, so I want to talk about some examples of this in our market. So first of all, there's a program called Blue Distinction. There's Blue Distinction Total Care, which is really on the primary care side, and there's Blue Distinction Specialty Care, which is more about specialty services. It's a program of the Blue Cross Blue Shield Association. For those of you who are newer, when we operate as RGA, we are an independent licensee of the Blue Cross Blue Shield Association, and we're part of the Blue Card Network. And so this program would apply there. Right now, we have a waiver that means we don't participate in this yet. And there's some very specific reasons for that. But know that this exists out there in the market. It's not something we're doing yet. It's a question for us for the future. So in this program, most Blue plans are required to participate. TPAs like us often have waivers that exempt us. There's an attribution methodology that's provided by the association that says this is how you do attribution. There's an algorithm that sets who belongs to whom. And then members are passive. So today, if you're an RGA member and you happen to seek care, for example, through providers that are participating in this, you may be attributed to them in some way and not even know it. It includes a mix of primary care medical homes and ACOs. In both cases, the provider receives some sort of fee-for-service payment upfront and a care coordination fee and some additional upside benefit if they achieve results. So much like my example I just shared. It's available in 35 states and 40 of the 50 top MSAs right now. And the average cost savings they're showing so far are $10 PMPM. So, and that's per member per month. A lot of what we do is PEPM, so this is member, not employee. So good savings thus far. So despite the attribution methodology, they are generating results. The systems have gotten pretty good at this. An example of this is Regence's program. Regence's program, one of them, is called Total Cost of Care, TCC. Again, it's attribution-based. Members are passive. They work with a number of ACOs in the Pacific Northwest. I've mentioned a couple here on this slide. And you can see that they are generating some results both in savings and quality metric improvement. So there's some promise in these models as they move forward. One of the reasons that there's been movement in this space has to do with the laws associated with Medicare. And we're going to talk about that in a minute, and I'll share with you kind of what are the laws that help to support this and where is it going. One other I'll mention, I've talked a little bit about UW. This is a good example. University of Washington employees are part of the public employee group. And so within that, there's an opportunity for certain public employees to participate in an ACO where it's an active choice. This is one where the member chooses to be in the ACO plan as opposed to the standard PPO plan. To date, there's about 17,000 members who've chosen this. My guess is that's because their premiums and deductibles are half of what they are otherwise. So people are cost sensitive. And they must seek care within the ACO. There are other services they can get elsewhere if they want, but you can see the cost differential. It's 15% coinsurance in the ACO, 50% everywhere else, including within just the network. So big differential for staying with the ACO. Since it started, they've seen improvement in most of the quality measures they've established, and the plan is outperforming the other plans. Now that may be because the people who are choosing it, there's an adverse selection issue in terms of who's choosing it or not. We see that sometimes with high deductible plans where people choose the high deductible plan if they don't use a lot of care, but certainly they're seeing some results with it so far. Anyone have questions? Yeah.
How is quality being measured? We talk a lot about how
Mm-hmm. Mostly they're process measures that can be done through claims. So did I get a pap smear this year? Did I get a mammogram this year? If it looks like I have diabetes through my claims, did I get the 5 things you're supposed to do for diabetes? And there's been a lot of movement on metrics in the last 15 years to say, like, these are the metrics that we think are the most important ones to achieve. Most of them use some variant of that. If you're interested in metrics, look at the National Quality Forum. They have a long list of claims-based metrics. Okay. So we talk about laws and regulation. This is where it gets interesting. Okay, so catch up on my notes. Catch a couple details for you. Okay, so there's been a steady kind of change in support of value-based care over time, and it's been a growth. There's been a growth of laws and then also dollars to support this at the federal level over a long period. The first medical home demonstration was done in 2006. So it's more than 10 years old at this point. That was included within the Tax Relief and Healthcare Act of 2006, and it mandated that there was a medical home demonstration. CMS, the Centers for Medicaid and Medicare Services, oversaw it. It was a demonstration done mostly in the Medicare population. And so that was kind of the first one. It showed good results. There was promising results. So there was some additional funding. So the Medicare Improvements for Patients and Providers Act of 2008. If you notice how our legislators really like wordy laws, gave some additional funding, $100 million in additional funding. So there's been a lot of funding to study this and to say, is this a good thing? Additional change with PPACA in 2010, so defined ACOs into law. So it just said what is an ACO. It codified it to say it's a certain set of things. And the law made the beneficiary participation passive. So everything that's done in Medicare and around ACOs is a passive population. So the members aren't choosing the ACO. Essentially, the ACO becomes responsible through some data-driven methodology of attribution. With PPACA, they established a shared savings program for the ACOs that were set up such that if the ACO achieved certain results, that they would retain some additional dollars. And so it created a fee structure to support the development of this. ACOs that wanted to participate on behalf of Medicare beneficiaries had to have at least 5,000 Medicare beneficiaries kind of in their patient pool. They had to participate for at least 3 years, and they had to measure quality outcomes and patient satisfaction. They also had to demonstrate patient-centeredness. There were some ways that they had to do that. You're welcome to read about that, but it was kind of a set of things they had to do. So in 2016, CMS reported results. They started reporting, and they've continued to do so. So in 2016, they've gotten to the point where they could say, we've got some ACOs that have been around for 4 years. So let me tell you about the results. So the ACOs in their first year were showing results of like 5 million. So not a lot. It takes a while to really be successful with this, both to build the infrastructure as well as to kind of get into your groove with what you need to do to actually be successful in coordinating care for people and getting the people into the right care. ACOs in their second year showed savings of $50 million. So this is annualized. So really significant savings. ACOs in their third and fourth year together showed savings of $297 million. So really exponentially big numbers in terms of these models, when they get mature, can do a really great job. Okay, so this, that was 2016. Anyone think about the political climate in 2016? Was it good? People collaborative? Is anything getting done in Congress? Generally not. Okay, except MACRA. MACRA passed the Senate with 92-8, which is almost shocking, like that they could agree on anything, right? I think the only thing that we've gotten similar Senate approval of recently was the opioid bill that just passed. Also 92, 93, I think that one was actually 98-2 in terms of in favor of doing something about opioids. So very occasionally Congress comes together and says, yes, this is the thing. So I'm pretty sure that 297 million might have been the driver of that. So MACRA, the Medicare Access and CHIP Reauthorization Act, essentially did more with regard to value-based care. It really put 2 programs into place, and they're all a mouthful, so bear with me, guys. So first, the Merit-Based Incentive Payment System, or MIPS, and the Advanced Alternative Payment Models, or AMPS, or APMs, I guess. So 2 different programs that were put into place. Both of these affect Medicare beneficiaries. So in case anyone's not aware, Medicare is the program that primarily is for people over the age of 65. There's also some room in the law for people with certain late-stage illness like ESRD, as well as people who are on disability to participate in that program, but mostly people who are 65 plus. And so these 2 programs were really designed around those people. So first, MIPS. There's a lot of detail on the slide. Essentially, MIPS was a program that said that provider payments could be adjusted plus or minus 5%, which is significant when you think about how many people providers see in the Medicare population and what a large portion of their total revenue Medicare represents. Just knowing, as people age, they tend to need more health care, and Medicare beneficiaries then make up a big portion of the dollars that are coming into a provider. So it could increase or decrease their payments by 5% in 2020. By 2023, it'll be plus or minus 9%. So pretty big difference. 9% doesn't sound like a huge number, but on the scale that we're talking about, it's really significant. And providers already feel like they're underpaid by Medicare, so plus or minus this amount of money is a big deal to them. To participate, providers had to report on various metrics, and their payment is adjusted based on performance in 4 categories. So one is quality. You can see, perhaps it's a little small. Quality is the biggest metric. Cost, also 30%. Promoting interoperability. Again, there's a bunch of stuff on this about how you work with others from a technical systems perspective. And then also improvement activities, just to show, getting better in terms of the primary care that you deliver, was a small percentage. And so what's interesting about this is that your performance in 1 year doesn't impact your payment until 2 years later. So what you did in 2017 affects 2019. So there's a really long tail with this, right? So there's a long tail in terms of getting your care in order and affecting the population. The population that you served that you might have done really well with in 2017 may not be the population you're serving in 2019. And so it's a pretty difficult thing for them to plan for. Mhm. It's a very involved methodology that I'm going to have to point you to go read. So it's not simple. So again, there's a big requirement for infrastructure to show your results on the population level. So most small providers can't participate in this type of thing. One, because they don't see enough Medicare beneficiaries, and two, they don't have the infrastructure. So. Okay, so advanced alternative payment methodologies. So essentially, this is an incentive program for primary care to get a bonus of up to 5% on their Part B payments. So all of the outpatient care that providers are delivering to Medicare beneficiaries. Again, they have to participate in an ACO program. They had to meet requirements on quality improvement and interoperability. So very similar sorts of models. It's just for a different group of providers that met the requirements to be an ACO. And again, there's this kind of upside bonus potential for them if they participate. What's interesting, though, is on the alternative payment models, cost was proposed to be an element of that. And when the final regs were written, which happened to be after the election, they omitted cost. So it's quality, satisfaction, interoperability, improving things, but nothing about cost. So it's interesting. Okay, thank you. Okay, so where do we go from here? So I guess don't get excited yet. So we look at all this and say, wow, there's some models that are generating pretty good savings. You know, you look at what's happening in the commercial population, you look at what's happening in terms of the results that have come from some of these demonstration projects in Medicare. One would say, awesome, let's keep going, right? Macro would say the Senate thought so too. Interestingly, the current administration is backing off of value-based care and making it mostly voluntary as opposed to the direction that the prior administration was promoting, which was to make it mandatory. So now it's kind of, if you want to participate, great. And if you don't have to. They've omitted cost from many of the aspects of what they're pursuing. So while we may be improving quality, and one would hope that there's a corollary from quality to cost, actually making achievement on cost a prerequisite for higher payments has been pulled. So I would suggest that, one of the things that will really determine the outcome of this and whether it really goes anywhere will really be dependent on elections and who is in control in the administration. So where CMS was really leading the charge through the Obama administration in particular, they stepped back quite a bit on this particular element. And so, it's kind of a question as to whether, through Medicare and Medicaid, which, are huge populations of people, whether they're going to pursue that or not. The other thing, employers really aren't demanding this, and that's part of the reason we have a waiver. When we've talked to employers, it's, what we can say is you definitely have to pay extra for the care coordination fee. The provider is held to standard on a population, but it may not be your people who they achieve better results on, right? So if I think of this whole population and I say these couple of tables belong to employer A, I can't tell employer A that they saved money. I can only say that they were in the group that collectively saved money. And that's a hard sell to employers to say pay more. Also, this is complex stuff. It's hard to talk about all the different attribution methodologies and all the prospective and retrospective risk scores and different things that have to be applied. And so people get lost in it and go, okay, like enough. And then, I think the commercial models mostly have been dependent on the Medicare models because there was so much money at risk and potentially becoming a mandatory requirement for providers who provide care to Medicare beneficiaries, and they were doing it anyway, and so it made sense to continue with the commercial population. If that's not true, and that's their primary revenue source, then there may not be the necessary demand to justify the infrastructure development on the commercial side. So it's kind of to be determined what's going to happen. But there is some hope. So a couple things, certainly on the specialty care side, we're starting to see some bundle payment models that have, at the very least, some kind of case rates for services. You're not just getting paid for more. And in some cases, starting to look at quality outcomes with that, to say you get paid, not only did you do the service, but then the person didn't have readmissions and continued problems. So that might be a place for some opportunity. There are primary care products out there, direct primary care products, where employers can buy direct from a primary care medical home and say, I'm going to pay you a capitated rate, and maybe you put fees at risk for it, but it exists outside of all the larger kind of government and payer structures. We have some clients who utilize those. And we may see some jumbo employers that have enough people in one place really take a leadership role In this state, we've seen the healthcare authority do that. So they run the state employee programs, as well as some of the other public programs. And they've really taken a leadership role in saying we want to pursue this, and have embedded that within their RFP requirements for the health plans that serve them and the providers that serve them. We may see something similar with the Amazon, JP Morgan Chase, Berkshire Hathaway thing. So to be determined, but the leadership for this may come from different places than where it's been in the last 10 years, which has really been driven through Medicare. But that is all I have for you today. Does anyone have questions? Yeah.
The models that include cost as part of the calculation, does that include prescription medications or just medical?
It's both. Questions? Okay. There's a lot happening in this space, so I encourage you. It's interesting, and I think it'll be really interesting to see how this plays out. It's a really interesting thing as we think about how do we fund healthcare over time? How do we help our employer customers fund healthcare? How do we help members make good choices about where they seek care? So I think it's an evolving area that'll be interesting to watch. So encourage you to kind of keep your eye out for things in the space of what's happening, and let me know if you have any questions outside of the session. So thank you.